senior colleague, Professor Partho Sarkar. Now, Partho Sarkar, please introduce a chairman and start the proceedings.
Okay, good morning, everybody. I have the pleasure to introduce Professor M.K. Rai, who will be the chairperson today. He is basically known to everybody, both in our state and nationally. He is a neurologist by profession and an internist by passion. So it will be much less whatever I say about him. He is teacher of the teachers. So without wasting any time, I will ask our chairperson to introduce our very eminent speaker, Professor Jyotirmoy Pal, President API. So over to Professor M. K. Rai, please.
Thank you, both the Sarkar sirs, Professor R.N. Sarkar and Professor Partha Sarkar. And also, I extend my thanks to Professor Partha Karmakar for asking me to chair this very important session, which will be dealt with by now no less than a figure all over the country, Professor Jyotirmoy Pal, who is presently the head of the Department of Medicine, Sagardattu Medical College. You all know. And along with these things, is a lot of acknowledged to his credit. He is presently the president of our association, API, and is a dynamic personality and a person by heart. Is an excellent, soft nature, along with his very stern attitude in some situation to overcome any sorts of difficulties, so far the administrative part is concerned. Now he is a teacher in the sense that he has taken the master class when I started on neurology. He has got a very passion on the neurology. So this case, particularly the 60-year-old male, is a case-based discussion. So what he has done, probably I think, that case will be presented by some of his PGTs. And on the course of this discussion, presentation, he will be asking some questions and some moderations, and I will have some comments from time to time when asked for. With this few introduction, I request Professor Jyotirmoy Pal to proceed further with this case, along with this plan of strategy of presenting the case.
Thank you, Dr. R.N. Sarkar, Dr. Karmakar, for giving the opportunity. But I thought that we should present a real case. And basically, our is forum for the students. So how the student present and what are the common questions asked in the exam and what are the lacunae mistakes. That is our main target. So that is why I have chosen a case which was admitted in our unit only few weeks back. And it will be presented by our two students, one second year and first year, Dr. Shatabroto Bera and Dr. Akash Gupta. I have a privilege that I am getting a galaxy of the teachers to moderate the cases. Dr. Professor M. K. Rai, Dr. Nandini Chatterjee, Dr. Karmakar, Dr. Subhasis Chakraborty. He is also Professor of Anatomy from College of Medicine in Sagardattu College. Dr. Shekhar Chakraborty, also we have Dr. S.B. Ganguly, Dr. R.N. Sarkar, Dr. Partho Sarkar. So this is the open discussion. I have kept more internists than neurologists because our students will be taken exam by the internists. So what are the common questions asked by the internists and what are the mistakes that is to be identified. This is not this is the students be confident. Whatever answer you give, we teachers are there to correct. Okay, so first I request Dr. Shadavarto, you present your case.
Good morning, sir. We had a 60 years old male who presented with sudden onset loss of sensation in entire face and right side of body, followed by sudden onset right-sided weakness and slurring of speech for last 6 hours.
So these are three component: one-sided weakness, loss of sensation, and also the facial sensation loss and slurring of the speech. Three major complaints for which patient attended the our emergency. Next, proceed.
In history of present illness, a 60 years old hypertensive male presented with sudden onset loss of sensation of right side of body and entire face for last 6 hours. There was no hyperesthesia, tingling or band-like sensation. Subsequently, he developed right-sided weakness of body.
So here most important, I have made the red color that instead of half of the face, entire face is involved. And first started with major symptom was the sensory, followed by facial sensory loss, then some weakness developed in the same side, that is the right side. Now proceed.
He had difficulty in swallowing both solid and liquid food, which was associated with nasal regurgitation, cough when swallowing saliva. He also complained of difficulty in initiating the swallowing. He was complaining that his food was sticking to the mouth. There was no pain while attempting swallowing or heartburn. He also had sudden onset slurring of speech. There was difficulty articulating, but no word finding difficulty was there. Slurring was constant, not fluctuating, and was not worsened by fatigue. It was also associated with hoarseness of voice.
So here patient has a difficulty and nasal regurgitation in swallowing, and also nasal regurgitation, cough while swallowing, and along with the slurring of the speech and difficulty in articulation, not in understanding or word finding or preparation of the answer, but articulation. There is a defect in the articulation and also hoarseness of the voice. So now next.
There was no history of headache, vomiting, difficulty in reading or comprehension. However, history of vertigo was present. There was no history of bowel bladder involvement, no history of diplopia or any vision abnormalities. There was no history of fever, seizure, loss of consciousness or altered sensorium. There was no history of trauma or substance abuse. The patient gave no history of known malignancy, recent weight loss or night sweat. There was no history of joint pain or photosensitivity, no history of shortness of breath, orthopnea or PND, no history of chest pain, palpitation or claudication symptom, and there was no history of decreased urine output, hematuria or any uremic symptoms.
So here salient very important points are: one is no difficulty in reading and comprehension, and no diplopia, no seizure, but vertigo was present. This is among the negative history. This is the few histories which is important, and that is why I make a bold color. Okay. So coming to the next important past history.
In past history, there is no history of type 2 diabetes mellitus or any heart disease like rheumatic heart disease, atrial fibrillation, valvular disease, or prosthetic valve or disease or prosthetic valve changes or recent MI. No history of tuberculosis, meningitis, HIV, or chronic ear or sinus infections. There was no similar past history.
So this is the important past history. So now analysis from the history. So Sadabarto, so what are the important history that you have elicited from the patients?
So first there was a hemianaesthesia in the right side, which was followed by right-sided hemiparesis, and there was loss of sensation in the entire face. Patient also had slurring of speech, difficulty in articulation, vertigo, nasal regurgitation of food, along with dysarthria. There was no history of seizure or loss of consciousness.
Okay, so these are the important history. So Dr. Akash.
Yes, sir.
So from the history, what differential diagnosis or what are the anatomical localization you can do from the history? If you analyze the history.
Sir, from the history, we can localize the.
What are the structure involved from the history that you can? Hemianaesthesia and hemiparesis in the right side. That means?
Sir, there is descending tract, sir.
That means corticospinal tract and
yes,
spinothalamic tract is involved.
Yes, sir.
Okay. Loss of sensation in the whole face means?
Sir, posterior column tract.
No. Face is drained by the trigeminal nerve.
Yes, sir. Right.
So that means fifth nerve is involved. Okay. Fifth nerve or his nucleus or his branches is involved. Slurring of the speech. What is your interpretation? Slurring of the speech.
Sir, 10th cranial nerve.
But this patient has no comprehension difficulty, no difficulty in naming, no difficulty in word finding, but there is slurring of the speech. And also patient have history of some hoarseness of the voice. So what are the structure involved?
Sir, 10th cranial nerve nucleus.
Not clunk. That means the articulate that is the product sound is produced by the vocal cord. So that is the hoarseness of voice, and it is modified by the laryngeal pharyngeal muscle along with the tongue, palate, lip, buccal muscle. So this is called articulation. So that means either in the vocal cord or the muscle responsible for the modification of the sound, and these muscles is governed or controlled by the different cranial nerves. Okay. So either 9, 10, 12. So either the cranial nerve or its branches or of these muscles or its supranuclear connection is affected. No seizures means
Uh,
what is the importance of seizure? Seizure usually happens. This is a case of stroke. Okay, cerebrovascular accident. If there is a cortical lesion, there will be seizure. But subcortical lesion never produces a seizure. The no seizure means it is unlikely the patient have a cortical seizure. Then patient has vertigo. What is the interpretation of vertigo?
Sir,
Vertigo
vestibular.
we usually see when there is the involvement of the vestibular nucleus. Okay. So from this history, now Dr. M. K. Rai, your comment? Dr. Roy?
Yes.
So
I
may I
think he
proceed?
has analyzed, but you should be a little bit broader perspective in the because up to MD is okay, fine. But somebody can ask you more than that. Hemianaesthesia doesn't always mean that you have got a lesion in the spinothalamic tract. Yes, definitely spinothalamic is the most important tract which is involved. But ultimately, you must have to remember that everything is to be perceived by the cortical area. So usually speaking, if there is a lesion in the ultimate destination of the spinothalamic tract,
Sensory
from
cortex?
the ventral posterolateral nucleus to your cortical area, that means in the parietal sensory cortex, then even if there is a very big lesion in the cortical area, you can get a semisensory. But however, it should be a very big lesion, and at that time, the patient probably would have succumbed. So usually in clinical practice, we think that it is the descending spinothalamic tract which is most commonly involved, not the cortical area. This is one important. Right hemiparesis, which means that the patient has got that weakness on the right side of the, so the corticospinal tract must be involved. Otherwise, you don't get like that. So one is you have told either cortical level or subcortical level, you can get the hemianesthesia in the form of spinothalamic tract involvement. Hemiparesis in the form of your corticospinal tract involvement. Whole sensation of the face is gone. Whole sensation means the entire side of the face, right side as well as the left side. That means the nucleus, descending tract of the trigeminal and the nucleus, it should be involved bilaterally. Otherwise, you cannot get the whole sensation loss. This is important. Slurring of the speech, Dr. Pal has nicely told that the slurring of the speech is basically dysarthria. Dysarthria may be either due to a problem. He has already told a muscular problem.
Dr. Dysarthria, I will come later on to you.
Yeah, the slurring of the speech he has told is due to your 9th nerve, 10th nerve, and the facial muscles he has told. I mean, muscles of the tongue, muscles of the palate, etc. He has mentioned. But never forget one important thing. It is not a language problem. Slurring of speech and dysarthria he has written simultaneously. This slurring is actually another term is dysarthria. So dysarthria may be either it is due to the upper motor dysarthria, lower motor dysarthria, cerebellar dysarthria, or extrapyramidal dysarthria. So whatever may be, the dysarthria means there is no cortical involvement. Rather, it is an involvement where there is no language problem, but articulation of the problem is at fault. She has already mentioned. Seizure he has mentioned. Seizure is usually we know that the seizure is always cortical origin, but never forget that if there is a strategic lesion in the thalamus, you can get the seizure. Nasal regurgitation he has already told. And about vertigo, I like to mention one thing. Not only the vestibular nucleus, but sometimes even the cerebellum is involved. You can get the vertigo. You can get the lesion in the brainstem, either involving the vestibular nucleus or its connection. You can get vertigo. Or even the peripheral vestibulopathy in the ear, you can get also vertigo. So these are the comments from this.
Okay. So proceed for examination.
On examination, on doing general survey, patient was conscious, oriented, cooperative, and obeyed commands. His BMI
Just
was
mention
20.
the important positive points.
There was no abnormality in the pulse. Rate was 100 per minute, regular, normovolemic, normal in character, no basal wall thickening, no radioradial or radiofemoral delay. All peripheral pulses were synchronous and equally palpable.
So here examination of the peripheral pulses, whether there is any bruit, signs of atherosclerosis, that is very important, or any any irregularly irregular. That means atrial fibrillation is there. That is very important when you are examining the pulse. Now, proceed.
On measuring blood pressure, the pressure was 130 by 90 millimeter of mercury in sitting position in both the arms. There was no postural drop in blood pressure. Respiratory rate was 18 per minute, abdominothoracic. No usage of accessory muscles was seen. JPP was not engorged. Temperature was 96 degree Fahrenheit in right axilla. Oxygen saturation was 98% in room air. And on physical examination, pallor, cyanosis, clubbing, jaundice, edema, and lymphadenopathy were absent.
Okay. So now we are coming to the actual neurological examination. Tell me.
On neurological examination, he was a right-handed person who can read and write. His higher mental functions were normal. He was conscious, oriented to time-place person. Memory, both all immediate, recent, and remote, were intact. Intelligence and mood were normal. Concentration and calculation was intact. His speech was desultory, hoarse, slurred, and hypernasal in character. The voice was breathy, hoarse, and there was poor articulation. Repetition, comprehension, and naming were, however, intact. Apraxia, hemi-neglect, and hallucinations were absent.
So here to remember the speech, it has a two component. One is the language, one is the speech. Language means your understanding and your command for the answer. But actual command is produced by the vocal cord. So here the repetition, comprehension, naming intact means less likely this patient have a cortical lesion because these are the cortical feature. It's the language. It is the property of the language. Then another component, now through the corticobulbar fibers, the cranial nerves, they have a action on the vocal cord and the muscles of the larynx, pharynx, tongue, palate. So sound is produced by the vocal cord. So if there is abnormality in the vocal cord movement, there will be dysphonia, phonation, problem in the phonation, dysphonia, that is often presented as a hoarseness of voice. So when sound come out from the vocal cord, now it is modified by the different muscles. These muscles are governed by the different cranial nerves. So either supranuclear connection of these cranial nerves or cranial nerve involvement or muscles or his peripheral nerve or the muscles itself, there is a tongue, palate, larynx, pharynx. If there is any abnormality, that will cause the dysarthria. So now question, how to approach to a patient with dysarthria? Dr. Roy or Dr. Chatterjee, anybody, Dr. Roy? Just brief, you already described. So
Nandini,
here
do
we
you
can
like
say...
to comment on? Nandini, do you like to comment on? Already I have told.
Told. Basically, it can be neurological, non-neurological, but here we are dealing with the neurological cause of dysarthria, but there is also non-neurological cause, suppose respiratory muscle or teeth problem. These are non-neurological cause, can also cause the dysarthria. And neurological cause, I already told, cranial nerves, supranuclear connection of the cranial nerve. Again, I am repeat, cranial nerves governing this muscle, they are peripheral nerves or muscles. Any problem in any of this loop will cause the dysarthria. It can be spastic, flaccid, ataxia, hyperkinetic, mixed. In another class, we'll describe the how to approach to a speech and language disorder. So now we are coming to the very important cranial nerve examination. Because this patient has dysarthria, so examination is very important. Shadavarta, proceed.
On cranial nerve examination, the olfactory and optic nerve examination revealed no abnormalities. On examining the oculomotor, trochlear, and abducens nerve, there was no ptosis, no deviation of eyeballs, exophthalmos or enophthalmos at rest. Extraocular movements were not impaired. Pupils were bilaterally reacting to light. Direct and indirect light reflex were present, and accommodation reflex was also present.
So here, third, fourth, first, second, third, fourth, normal. It is not moving. Just 1 minute. No. Chalo. Pupil, now, come.
And the patient had while examining the eye, the patient had a nystagmus. The nystagmus was present in the primary position. It was gaze evoked, increasing on right gaze. It was suppressible, which was partially suppressed by fixation. The nystagmus was mixed in nature, horizontal with a torsional component, with the first face directed to the right, and the direction of the torsional component was the eye was rotating clockwise from examiner's viewpoint.
Okay, so can you run the video? Acha, I'm not. So now next question is, so this patient has a nystagmus, that is first component towards the right. There is a torsional component and first component and partially it is suppressible. So next issue is very important issue for the student. What is nystagmus? So Dr. Akash, can you give some light on what is nystagmus? What are the different etiologies of nystagmus and how will differentiate basic two, one vestibular, one cerebellar nystagmus?
Yes, sir. So coming to nystagmus, so nystagmus is a continuous uncontrolled to and fro movement of the eyes. It consists of two alternative movements, that is a slow drift and a corrective quick phase. In slow drift, sir, it takes the eye away from the preferred direction of gaze, and in corrective phase, it brings the eye back towards the visual target. Coming to the etiology, there can be neurological and non-neurological. In non-neurological, commonly seen in physiological nystagmus, congenital nystagmus, drug-induced, or it can be ocular due to ocular diseases. In physiological nystagmus, it occurs due to lateral in extreme of gazes, and there is no other neurological finding as it seen in the neurological nystagmus. Congenital nystagmus occurs from the birth due to various ocular diseases. It can be also due to neurological causes such as vestibular, positional, gaze evoked, or gaze paretic nystagmus.
And so if I can very simply describe to the student what is nystagmus, our basic physiology is want to hold image steady on the retina. Otherwise, I cannot see clearly. And second, I have to direct phobia directly to the object. This is the two basic physiology. One, hold image steady on the retina, so it will not be blurred, and to direct phobia directly to the object. This is the two major physiological function of our eye and associated eye muscles and nerves controlling the eye movement. So the physiology that is responsible, or physiological system that is responsible to hold image steady on the retina, these are the fixation. One is the fixation, one is the action of the vestibular nucleus, and another is the optokinetic movement. And to direct phobia directly to the object, that means I want to see a mosquito who is moving, my eye will be fixed to the mosquito. Here the saccades, or some, I am in the train, some one lamp post is moving, I am fixing my eyes to the lamp post. My train is moving, but my eye is fixed to the lamp post. Here the saccade, pursuit, and vergence. Three movement basically direct phobia to keep always constant on the object. So these are the six mechanisms who is responsible for preventing blurring of the object. So if there is any defect of this six system, that will lead to the nystagmus. That means our eye cannot fix to the either to the primary position. It will be there will be to and fro movement. There will be drifting from one side to another side, or our eye cannot fix to the particular object. You are asked to follow the bird who is moving. So your eye should be fixed. So if there is a defect of this six system, what I have told, saccade, pursuit, vergence, vestibular system, fixation, optokinetic, our eye cannot fix to the moving bird. Okay, it will drift. So this drifting and to and fro movement, this is called the nystagmus. So nystagmus, how it happens? I am taking one example. What happens in case of vestibular lesion? I have a right and left-sided vestibular nucleus in the brainstem. Vestibular nucleus give a movement for the pursuit, responsible for the pursuit. That means right-sided vestibular nucleus, they give a impulse to push the eye to the lateral rectus, sixth nerve, to push the eye to the left side. So right-sided vestibular nucleus giving a pursuit movement to drift the eye to the left side, and left-sided vestibular nucleus giving impulse to push the eye as a pursuit movement to the right side. If my two vestibular nucleus is okay, by the action of the both side, it will neutralize and my eye will be fixed to the in front to the primary position. Okay. So suppose you assume there is a right-sided vestibular nuclei. What will happen? For impulse from pursuit impulse from the right side will be impaired. So from the left side, impulse will be on. So I will gradually move to the right side. Okay, by the action of the left vestibular nucleus. Pursuit is a slow movement. So I will be gradually slowly move to the right side. It will not be neutralized by the action from the right-sided vestibular nuclei as right side is injured. So when I will move to the extreme, then the frontal lobe will give a saccading impulse. So after saccading impulse, my eye has moved to the right side, extreme position. By saccading movement, again it will come back to the original position. So this is the first phase. So first phase by the frontal lobe, slow phase by the vestibular nucleus. So if there is a lesion in the right-sided vestibular nucleus, what will happen? Slow phase will be towards the lesion. First phase will be away from the lesion. So there will be nystagmus, one slow phase by the opposite healthy vestibular nucleus, that is pursuit. Another, there will be the first component by the frontal lobe. So this is called simply the nystagmus. Second question, nystagmus we can get in different disorder. One can be, Akash told correctly, can be physiological, can be ocular disease, can be drug induced, can be vestibular lesion, peripheral, central, cerebellar, or this connection, that is peduncle. It can be positional, it can be congenital. But neurology, we basically we are concerned with vestibular versus cerebellar nystagmus. So students must know how we differentiate between the vestibular nucleus and nystagmus versus cerebellar nystagmus. In vestibular nystagmus, slow phase will be towards the lesion. First component is opposite to the, away from the lesion. That is opposite to the cerebellar nystagmus. In vestibular nystagmus, there will be rotatory component, which is absent in cerebellar. Maximum impulse in case of vestibular nystagmus will be when patient looks away from the lesion. That means if there is a right-sided vestibular impulse, maximum impulse when patient will look to the left side, away from the lesion. That is opposite to the cerebellar. And partial fixation is possible with the vestibular nystagmus, not possible with the cerebellar. And very important is a unidirectional. That means whatever the head position, if there is a right-sided vestibular injury, always first component will be towards the away. That means to the left side. If there is a right-sided injury, always to the left side. But in case of cerebellar, it is bidirectional. That means the towards the gauge, there will be first component. If you ask the patient to the right side, the first component will be right side. If you ask the patient to gaze to the left side, first component will be to the left side. So this is the way how you can differentiate whether it is a vestibular nystagmus or cerebellar nystagmus. In this patient, there is a torsional component. Okay, and first phase was to the right side. That we will analyze later on. So now come to the fifth.
On examination of trigeminal nerve, there was loss of pain, temperature, and touch and proprioception of the entire face. The motor component was intact, and in the reflexes, bilateral corneal reflex was reduced, jaw jerk was normal.
So, 1 minute. So next question, what are the nuclei of the cranial nerves and what are the manifestation of the fifth cranial nerve nucleus? Any first Sadavarto react, then the students will react. What are the nuclei of the cranial nerves?
Cranial nerve can be broadly divided into two groups. One is
you
motor,
take the help of the picture.
So one is motor nuclei of trigeminal nerve and the rest are the sensory nuclei. Among the sensory nuclei, first comes the mesencephalic nucleus, which extends from midbrain to the pons. It receives proprioceptive information from the masticatory muscles. And then comes the principal or main sensory nucleus of the trigeminal nerve, which is located laterally in the pons. It is responsible for carrying tactile and proprioceptive sensation mainly. And then comes the spinal nucleus of the trigeminal nerve, which extends from pons to upper cervical cord, and it receives pain and temperature. So the motor nucleus is at the mid
summary, there
level,
is motor nucleus in the pons responsible for giving impulse to the muscle of mastication. Sensory nucleus has a three component. One is the mesencephalic. They receive the proprioception. Second is the main principal sensory nucleus. They take the tactile and touch, and pain and temperature, that is basically by the spinal nucleus of trigeminal nerve that extend up to the cervical, up to the upper cervical region. So pain temperature by the spinal nucleus, and main sensory component for the tactile. Very interestingly, that so schematic picture. This is the main sensory nucleus, and this is the spinal nucleus. When the sensory fibers enter, touch enter here, it crosses the midline and go up as a trigeminal lemniscus. But in case of other pain and temperature, they descend up the upper cervical cord. So then it crosses the midline, then it go up, and together they reach to the thalamus. So this is important, this knowledge, because if there is a high cord lesion here, this is the foramen magnum. So there will be dissociative anesthesia in the face. So that is why when we examine the face, you should examine separately touch and pain temperature. So in high cord lesion, pain and temperature will be lost, but touch will be preserved. So this is one example of the dissociative anesthesia, and very important clinical findings when you will examine the facial sensation. You can understand whether your lesion is in the brainstem or in the cervical cord. In brainstem lesion, both touch and pain temperature will be lost, but in the cord lesion, only pain temperature will be lost. So so this we have discussed already. So now next about the other cranial nerves.
On examination, facial nerve and vestibular nerve were intact. In the glossopharyngeal nerve examination, the uvula was deviated to the right side, gag reflex was absent in the left side, and the voice was hoarse. On examination, the spinal accessory and the hypoglossal nerve were intact.
So we got the uvula gag reflex absent. So Akash, can you describe briefly the anatomy of the cranial nerve? Dr. Chakraborty is there.
Yes, sir. Coming to the anatomy.
Describe anatomy of the 10th cranial nerve.
Yes, the 10th cranial nerve. Sir, it is a mixed nerve that supplies motor, sensory, and parasympathetic fibers. Sir, it consists of 4 nucleus, that is dorsal motor nucleus, nucleus ambiguous, solitary nucleus, and spinal trigeminal nucleus. Sir, dorsal motor nucleus, it is situated in medulla oblongata, near to the fourth ventricle, and it sends preganglionic parasympathetic fiber to the heart, lung, and abdominal viscera. Nucleus ambiguous, it is in the reticular formation of the medulla. From there is the origin of the spatial visceral afferent that provide motor innervation to the pharynx, soft palate, larynx muscles, which are involved in swallowing and phonation. Solitary nucleus, it is a vertical column in dorsomedial medulla, which receives general visceral afferent fibers and spatial visceral afferent fibers and thoracic and abdominal organs. And spinal trigeminal nucleus, it is in the brainstem, which receives general somatic afferent fibers from the dura mater, external ear, and its external auditory canal. This the nerve leaves the brain between
because to understand the neurology, you should understand the anatomy very properly. Okay, and often this question is given in the exam. So basically, to understand the gag reflex, you must have the knowledge of the of this circuit. So sensory component taken from the posterior 1/3 of the tongue and the larynx and pharynx, the sensory component taken by the 9th and 10th, and they transmit, they relay to the nucleus of tractus solitarius. This is the nucleus of tractus solitarius. Okay, and the motor has a 2 component. One is the dorsal nucleus of vagus. They give parasympathetic to all the viscera, lung, stomach, other organ, intestine, heart, parasympathetic fiber. But nucleus of ambiguous, that is for the somatic efferent. So one is the visceral efferent by the dorsal nucleus of vagus, and somatic efferent from the nucleus ambiguous. Somatic efferent from nucleus ambiguous go through 3 cranial nerve. One is the 9th, one is one muscle stylopharyngeus, most of the muscle via 10th and 11th. So nucleus ambiguous give somatic efferent via 3 cranial nerve, 9th, 10th, and 11th. mostly by the 10th to the laryngeal and pharyngeal muscles. So when you touch something in the posterior pharyngeal wall, it is taken up by the 9th and 10th, transmit to the nucleus of tractus solitarius, then relate to the nucleus ambiguous. Nucleus ambiguous send the efferent impulse. So there is a contraction of the uvula, laryngeal muscle, pharyngeal muscle, whatever the action we see in the gag reflex, that is from the efferent, comes from the nucleus ambiguous. So this is the circuit. So if there is any lesion in the brainstem that impair the nucleus tractus solitarius or nucleus ambiguous, or these are the peripheral nerves or muscle itself, that will cause the impairment of the gag reflex. Regarding gag reflex, one very important test, we do not, if you read carefully the MacLeod, swallow test, gag reflex test, the touching the posterior pharyngeal wall and see the contraction of the pharyngeal wall and the uvula movement, that is a traditional test. But MacLeod is very clearly mentioned to do the swallow test rather than the gag reflex. Dr. Sadavarta, why? Why swallow test is preferred in MacLeod clinical examination book over the gag reflex, which is traditionally done to assess the 9th and 10th function of the 9th and 10th cranial nerve. Sadavarta?
The gag reflex is cumbersome for the patient. That's
So,
why fully conscious
describe
patient
the swallow test.
in swallow test, the patient is subsequently given 3 teaspoons of water, and it is noted whether the patient is having absent swallowing, cough, or change in voice after drinking each spoon of water. And if there is no problem, then we give a patient a glass of water, and the patient is seen by swallowing if he is having any difficulty.
So these lines are quoted from the MacLeod. So this is the current test advocated by the MacLeod in their clinical medicine book, rather than the traditional gag reflex, that is the touching with the stick of the posterior pharyngeal wall. So now continue the examination findings.
In the motor system examination, there was no wasting.
Comment to it.
Dr. Chakraborty, please.
This swallow test is very, very important for any patient who is having the Ryle's tube. When the patient is Ryle's tube is withdrawn, then swallow test should be done whether the patient can hold the fluid or food material just before swallowing. This is very important. And
Okay.
if the swallow test is positive, then you can withdraw the Ryle's tube and the patient normally. Otherwise, there is a chance of aspiration.
Yes,
It is
yes.
particularly done by the internists in ICU.
That
because
means
elderly
whether the
patients are very
brainstem is
prone to
functioning.
aspiration.
If you very important comment, Dr. Chakraborty. Thank you. Any expert, Dr. Chakraborty, Dr. Roy, Dr. Chatterjee, Dr. Karmakar, Dr. Ganguly, Dr. Adisharkar, Dr. You can put the comment in between. Motor system.
Can I say something?
Yes, yes.
One thing, when we are examining the cranial nerves here, the patient could have been seen by the ENT surgeon because no comment has been made whether there is a vocal cord palsy or not. This is usually seen. Patient has hoarse voice, as has been mentioned. This is one thing. Another is, more than the uvula, we should mention about the palatal movement, Shatavartu, whether the palatal movement is sluggish. So you have mentioned that the gag reflex was absent. Also, we touch the palate and see whether it's, when we say ah, then whether it is rising up symmetrically or there is any asymmetry between the M-shaped facial opening. Okay, thank you.
Yes, Shadavarta, keep a note. Huh? Next time when we will write, you mention all this. So continue to the motor system.
On examination of the motor system, there was no wasting or deformities. Tone was normal in left upper limb and left lower limb. It was flaccid in right upper limb and right lower limb. Power was 3/5 in the right side and 5/5 on the left side. Reflexes of right-sided upper limb and lower limb were reduced, while the left-sided were normal. Plantar right side was extensor, left side was flexor.
That means right-sided power is reduced, plantar is extension. Okay. So now a very common question for all the students. Basically, what are the some questions on the clinical methods what are the steps in examination of the plantar reflex and what are the different plantar response. Now, how will differentiate from the withdrawal response? So, plantar reflex clinical methodology should be perfect. So, there are some clues that what we common mistake we do when we do the plantar reflex or we cannot remember. Some of the clues I will mention here. Expert teachers are there. I request them to comment in between. When the base position should be patient is supine, heel knee extended, and foot on the bed. Okay, there should not be much cold, should not be much hot, because cold reduce the response, hot increase the response. And you examine the patient, exclude before that. You exclude there is a patient has no thick sole, number one, and no osteoarthritis deformity of the toes. If there is a deformity, fixity, you cannot examine this. Take a blunt object, never the sharp object, and you go through the S1 distribution. That is exactly the lateral aspect of the sole. If you go medially, the grasp reflex will be activated. So exactly laterally from the heel, you have to go gradually up. In a sensitive patient, usually going to the halfway, you should get the plantar response. If you do not get, go to the up to the whole sole and turn medially along the base of the metatarsal, but never on the base of the first metatarsal. So, and very important, the strength of the stimulus, there should not be any painful object that can create the pain, and strength of the stimulus will be such that does not cause any discomfort, and put a constant pressure, start from the heel. So these are the important clues that you should remember before doing the plantar reflex. Dr. M.K. Roy? Dr. Roy? Or Dr. Sarkar?
You have mentioned all the things you have already mentioned, but importantly, one thing you should remember, I'm telling the students actually, that first of all, they will see the temperature of the feet. If it is a very cold temperature, try to rub the lower part of the feet. So the temperature should be a normal size temperature. Otherwise, in a very cold temperature, it is very difficult. This is number one. Number two, if you find any sort of an amputation, suppose a patient has got an amputation below knee, there is amputation. So at that point of time, you don't have any plantar. In that situation, what you need to do is that you have to press the stamp of the amputated leg, and you feel the tensor fascia lata to find whether there is a plantar is extended or not. This is one of the important things. And lastly, you have to remember that there are certain conditions where you can get the normally plantar is extensor in terms of normal condition. Suppose during the later part of the sleep, in the non-REM period of the sleep, if you go for the plantar, you find that is a normal patient, it will be extensor. In case of children below the age of 1 year, their myelin is not yet developed, so you can get the normal plantar extensor. In case of deep anesthesia, sometimes you can get like that. So these are certain exceptions for the physiological point of view to remember that before we are actually stamping it to be a pathological one. But plantar once extensor in a conscious known patient is always extensor, and that gives a very, very important sign. This year, we have written actually chapter on the plantar extensor. Recently published our ICP newsletter. So I will request everyone, there is a one page, you can go through it. Now, Professor Pal.
Yeah. Another thing I want to add, Jyotirmoy, we have seen that in many cases, it is better to do a Oppenheim test along with a plantar because it augments. So you don't have to put much pressure. So simultaneously do a squeezing of the shin of the tibia.
Squeezing of the calf. So here, very important plantar. I have kept this slide because this is one of the commonest examination method asked in the exam. One is the great toe movement is more important. Fanning of the other toes not very important.
Chairperson, sir.
And the first movement.
May I pass a comment?
Yes.
Chairperson, sir. May I pass a comment?
Yes.
So I remember from the discussions that is being made by.
You are mute.
basically going back to my studentship. So Professor M.K. Roy definitely will recollect that when Dr. Okay, so whatever discussion, am I audible?
Yes, yes.
Yes.
Acha, whatever discussion is being made, that is very lively and very, I think, very beneficial to our students. So what I like to say, my experience that from this discussion, I am going back to my studentship. So sometimes Professor M.K. Roy will definitely remember that Dr. Maiti, Professor Maiti was a very renowned neurologist at that time. He used to say that plantar is $1 million sign. So whenever you are going for eliciting plantar, you have to maintain all the protocols so that you won't be baffled or you won't be confused. So there is sometimes even the senior teachers as well as ourselves and the students, of course, they do confuse whether they will say whether it is withdrawal or it is extensor. Here, I like to mention a very simple comment what Professor Jyotirmoy Paul was just going to that, to have very, keen vigilance to the great toe movement. So that will definitely help you whether it is extensor or whether it is withdrawal. You have to keep a very close vigil to the movement of the ankle and your great toe. If great toe moves fast, then it is extensor. And if the ankle moves fast, then great toe extends, then it is withdrawal. That is to be kept in mind. So your importance to that movement, which one comes first, whether ankle movement or the great toe extensor. Depending upon that, if it is ankle, then you will definitely go whatever other things exhibit in your plantar extensor, it is withdrawal. But if great toe comes fast, then it is extensor if it shows extension. Am I correct, Dr.
Yes.
Dr. Roy and Dr. Paul?
Yes, withdrawal actually the avoidance reflex. When you are giving some noxious stimuli to the soul try to remove his hip from the stimuli. That is the withdrawal reflex. So there will be more flexion of the hip, knee, and dorsiflexion. So here very important is the great toe. Suppose if there is a great toe fast flex, then extend. So that means your response is flexion. If great toe fast extend, then flex. Your response is extensor. Whether other toes there is a fanning or not, that is very important. So great toe movement is the most important. And to remember, in some of the condition, you will not get the response of the great toe. One is if there is a tendon injury, there is the extensor hallucis longus injury, or osteoarthritis. I told at the beginning, deformity, fixity due to the osteoarthritis or rheumatoid arthritis, lower motor lesions, ALS, as it is a combination of both EMN and LMN, frontal lobe dysfunction, because there the grasp reflex will predominate. If there is a frontal lobe dysfunction along with corticospinal tract lesion, the frontal lobe finding is the release phenomena. There is the frontal lobe reflex, there is the grasp reflex. That will dominate. So that is why you may not get the extensor response in spite of having the corticospinal lesion. So this is the issue when we will get the no response. Another very important issue that everybody should keep in mind, when we get a very large hemorrhage in the basal ganglia, sometimes we get plantar not extend, that is the flexion, because plantar is a function of the CST, corticospinal tract, but intact extrapyramidal system is required to get the plantar response. If their extrapyramidal system is deranged, you will not get the plantar response. So that is why if there is extensive lesion in the basal ganglia, plantar response not found. So this is the one important, sometimes we confuse, we get the large hemorrhage in the basal ganglia, but we do not get the plantar extension. This is the extra explanation. At the extrapyramidal system is totally deranged or damaged due to the lesion. So these are the few clues about the plantar response. I request students to perform and practice repeatedly. So now come to the sensory. Chalo, proceed.
On examination of the sensory system, pain, temperature, and touch was decreased in right half of the body and whole face, while vibration, joint position sense, graphesthesia, and stereognosis were intact. The cerebellar signs were intact in left limb and cannot be tested in the right side.
Yes. So now question, what are the different sensory abnormalities found in neurological examination? This is very nicely written in the MacLeod. and different definition you should know. So what are the different sensory abnormality you find? Sadavarta?
So sensory abnormalities can broadly be divided into two groups. One is positive symptom, one is negative symptom. In the positive symptom, there are symptoms like paresthesia or dysesthesia, where paresthesia is tingling, pins or needles, dysesthesia is unpleasant paresthesia. And negative symptoms like hyperesthesia, where there is reduced sensation to a normal stimulus, or analgesia, where there is numbness or total loss of sensation. And there can be hyperesthesia also, where is increased sensitivity to a stimulus, and allodynia, where a non-painful stimulus is perceived as a painful one, and hyperalgesia, where the pain threshold is increased.
So when you are examining the sensory system, few tips for the students, you examine the face and limb separately, okay, because drained by the different system, and touch and pain temperature also separately. And second, when you are examining a sensory system, always go from the negative to positive. Never go from the positive to negative. So from the history, you have to identify what are the areas where there is a loss of sensation. So you have to proceed from the area historically loss of sensation, from that area to the area where the sensory system as per history is better. So otherwise, if you proceed from the positive area where the sensory, there is no sensory symptom, go to the negative area, there may be illusion effect. And patient can mistakenly, if you put in the positive area, positive means a normal area, patient will say, yes, can you understand? Yes. Can you understand 2? Can you understand 3? Then you put your pin in the area where there is loss of sensation. By the illusion effect, patient will continue, yes, 4. To avoid this, you continue from the negative to positive area. And these are the definition every student must remember. These are often asked in the exam. So any comment from Dr. Chakraborty, Dr. Ganguly, Dr. Sarkar?
No, it's okay. Very good. Nicely explained.
Okay. So now we are coming to the next.
For the one thing,
Somebody,
I would
Dr. Chakraborty, please.
Yes, during exam, it is sometimes difficult to examine the temperature sensation. I think I want to get a comment from Dr. M.K. Roy. As the pain and temperature are carried by the lateral spinothalamic tract, and the same, is it mandatory to test both the sensations, or if we we taste the pain sensation, that is can be extrapolated as a
Ideally, you have to take both. Ideally, you have to test both.
we taste
you are
both,
right,
but is
as far
it
as this,
necessary to do both?
but because of some of the pain fibers, though we say like that, this is touch and pain, touch, pain and temperature. Okay.
Yes.
So pain and temperature, they actually carried by the same. And touch has got two parts. One is your fine touch and one is your crude touch.
Yes.
So
Yes.
if this fine touch portion is by the posterior column, I mean, yes, and crude touch by the spinal column. So pain and temperature, though it is carried by the same fibers, but still we test it separately, because in sometimes there may be some disproportionate involvement of the same fibers. In the sense, some of the fibers which are carrying pain and temperature, they may be spared, as a result of which you may not get the exact complaint which is in correlation with your clinical finding. So in examination, one need to do the temperature, but the temperature sensation is very difficult to test in the examination. I agree. But what we do is that the tuning fork, if you take this lower part of the tuning fork, we usually cold. So you can put it like that to see the cold temperature. Or you, if it is if the patient allows, you can just give a blow of air. Just give a blow of air. I am showing you how to give it.
Okay. And another information, when we are doing the sensory examination, when you try to get the level or dermatobal level, always depend on the pain examination, not the touch.
Yes,
because dermatobal overlap from the touch is more,
because by
from the pain is less.
So
okay.
if you just give it like this, blow like this, you find the cold. But when you blow in that other way, reverse way, you get the hot. So in examination, sometimes cold water, hot water, it is difficult. But if the patient allows, you can put the sensory stimulus like that. This is for cold, this is for hot. This is a very crude way of testing.
Dr. Sadavartha,
What about
now
Minal, what about a swab of spirit? You used to do that. Spirit swab, which evaporates and give a cold feeling.
Yeah, you can do it.
No, but the cold and hot, there is a specific specification, temperature.
Temperature is
Two test tube. That is what is mentioned. I think that is to be followed. 4 degree and 38 degree. So summary, Sadavartha, summarize your history and finding. Then we will analyze your findings, how we can get the site, anatomical site of lesion. So Sadavartha, summary.
A 60-year-old
Only the salient features.
A 60-year-old hypertensive male presented with sudden onset loss of sensation of right side of body and entire face, followed by right-sided weakness of body. He had difficulty in swallowing both solid and liquid food, associated with nasal regurgitation, cough when swallowing saliva, and difficulty in initiating swallowing. He also had sudden onset slurring of speech with difficulty in articulating and hoarseness. On examination, primary position nystagmus was present, increased on right gaze, partially suppressed by fixation, mixed in character, horizontal with a torsional component, with the first face to the left and the eye rotating clockwise from examiner's view. Touch, pain, and temperature sensation was lost in entire face and on the right side of body. On ninth nerve examination, uvula was deviated to right, gag reflex was absent in the left side. On motor examination, power was 3/5 on right side and right plantar was extensor.
Extensor. So if we summarize, so one is spinothalamic tract is involved because of the right-sided pain and temperature loss. Trigeminal is involved because entire face sensory, there is a loss of sensory, and both pain, temperature, and touch is lost. That means trigeminal involvement in the brainstem area. Second, there is a absent of the gag reflex. If you are deviated to the opposite side, that means nucleus ambiguous is involved. Nucleus ambiguous present in the medulla. And trigeminal nucleus is present from the pons to entire medulla up to the upper cervical cord. So trigeminal present from pons to upper cervical cord, ambiguous in the medulla. Then inferior cerebellar peduncle is not sure because cerebellar examination cannot be done. There is nystagmus, but we have to determine whether this nystagmus is due to the cerebellar component or vestibular component. There is a corticospinal tract involvement, so there is a right-sided weakness. In the nystagmus, what we get, the one we are getting the torsional component, and another we are getting that first component towards the right side. That means towards the hemiparesis side. So this indicate if there is a hemiparesis in the right side, that means lesion in the pathological lesion in the left side. And here the first component is to the right side, was there. The previous side was wrong, it is to the right side. That means away from the lesion. That means this nystagmus most likely due to the involvement of the vestibular nuclei rather than cerebellum or its peduncle. So this is the explanation what we get from the findings and analyzing the structure involved. So now coming to the brainstem anatomy. From the brainstem anatomy, we can understand very clearly this is the hypoglossal nucleus. This is the midline. This is the medial lemniscus. Okay, this is medial lemniscus by the posterior column. Posterior column crosses and proceed upward to thalamus through the medial lemniscus. This is the hypoglossal, and this is the pyramid. This is the corticospinal tract. So if there is a lesion in the midline, there will be involvement of the hypoglossal. There is a tongue movement one. There will be more involvement of the motor presentation, more weakness of the limb, and there will be joint position, vibration sense will be more impaired as there will be medial lemniscus is involved. So if there is a lesion this area, these three structure will be more involved. But if there is a lesion in the lateral area, what are the structure will be involved? One is the trigeminal. This is the spinal nucleus is there. Trigeminal will be involved. Nucleus ambiguous and tractus solitarius will be involved. There is a sympathetic trunk. So there may be involvement of the presentation of a Horner syndrome. There is a vestibular nuclei and there is the inferior cerebellar peduncle. So if the lesion in the lateral side, there will be more involvement of the vestibular nuclei, though there may be vertigo nystagmus, there may be cerebellar sign because involvement of the cerebellar peduncle, nucleus ambiguous will be involved, so there will be impairment of the gag reflex. There will be involvement of the trigeminal fifth nerve nucleus, so loss of sensation may be found over the face. So this is the brainstem medullary cross-sectional structure. So if there is a lesion in the midline, the following structure will be involved. If the lesion in the lateral side, the following structure will be, these are the following structure will be involved. This anatomical knowledge will help us to understand clinical understanding where is the anatomical site of the lesion. So now we are coming to the localization. So from this knowledge, we can understand either there is the involvement of the left lateral medulla, so because of the involvement of the ambiguous, vestibular, spinal nucleus, but corticospinal tract not present in this lateral area. So to have some involvement of the pyramidal tract, either lesion has extended up to this area, this area, or in the pons there is a diffuse area. In the pons, corticospinal tract is dispersed. So any lesion in the pons, even a small lesion, can cause more involvement of the corticospinal tract. So from the medulla, there may be upward extension up to the pons. There is a pontomedullary junction to involve the corticospinal tract, or this lesion extend up to this area to involve the pyramid. Okay, these are the two possibilities of why we are getting corticospinal tract along with the features of involvement of the lateral part of the medulla. So now is the open discussion. What are the anatomy of the corticospinal tract? So Shatavartha, can you just brief on 1 minute?
Sir, corticospinal tract originates from the corticospinal tract originates from the primary motor cortex.
Originates from the primary motor cortex,
then
along with the premotor cortex, supplementary
and supplementary motor cortex, and then there is formation of the
passes through the internal capsule.
Radiata passes through the internal capsule, then comes to the midbrain pons, and then there is crossing over.
The midbrain, then pons. Pons then come to the medulla, lower of the medulla. So it starts from the primary motor cortex, along with some fibers from the premotor and supplementary motor area. The premotor and supplementary motor area give the planning of the motor activity, and primary cortex basically for execution of the activity. But these fibers are basically for the crude movement. So they come through the internal capsule. Internal capsule, face and upper limb in the anterior part of the posterior limb of the internal capsule, and lower limb, they more in the posterior part of the posterior limb of the internal capsule. Then they come to the midbrain. In the midbrain, then through the cerebral peduncle, there is the anterior part, and between the two cerebral peduncle, third nerve come out. Then it come to the pons. In the pons, it is dispersed. On the pons, some of the fiber go to the cerebellum as a pontocerebellar fiber through middle cerebellar peduncle. Then after pons, it become condensed and condensed in form of the medulla. So that is why if there is a lesion in the medulla, there will be dense hemiparesis. But if there is a lesion in the pons, the hemiparesis may not be so severe. So in the medulla, through the medial part, it passes to the foramen magnum. In the foramen magnum, it crosses to the opposite side and go to the supply to the anterior horn cell. But here to remember that that when it crosses the lower fiber, upper fiber crosses rostrally, and lower fiber, limb fiber, crosses the midline more caudally. Okay, and that is the basis of cruciate hemiparesis. So upper fiber crosses first rostrally, lower fiber crosses more caudally, and 85% fiber crosses at the foramen, that is at the foramen magnum. So 85% the crossed fiber, but 15% fibers are the uncrossed fiber. They directly end to the anterior horn cell, and the crossed fiber, 85% fiber, they drain to the intermediate zone of the gray matter of the spinal cord. From there, through interneuron, they stimulate the anterior horn side to give the desired movement. So this is the basic anatomy of the corticospinal tract. So corticospinal tract crossed fiber responsible for the crude movement, and uncrossed fiber basically they are responsible for the finer movement, particularly the movement of the distal hand for more accurate movement. So this is the basic anatomy of the corticospinal tract. So what are the peculiarities of CST lesion compared to the LMN lesion? Here to remember that one is CST responsible give more fiber to the distal extremity. So voluntary activity, skilled activity, this is basically controlled by the CST. But as extraperoneal fiber, they supply more to the proximal fibers and more the gait, proximal limb movement, crude movement. And another important compared to the lower motor disease versus the CST involvement, CST basically affect the movement, not the individual muscle. For example, suppose there is a CST lesion for the external rotator of the shoulder. If there is a lower motor disease, there will be of a nerve. There is a lesion of the suprascapular nerve. Only the infraspinatus will be involved. But CST never involve a particular nerve or particular muscle. A particular muscle responsible for a movement. So external rotation is done by the infraspinatus and teres minor. Infraspinatus by the suprascapular, teres minor by the axillary nerve. So if there is a CST lesion for external rotator, both of the muscle will be paralyzed. So this is the peculiarity of a pyramidal tract lesion compared to the LMN lesion. So another is the preferential weakness. So number one, distal muscle is more involved, and the all group of muscle is not equally involved. That is why in the corticospinal tract, what we see, hand position is like this, because the what are the upper limb, wrist, finger, elbow, extensor, supinator, and abductors will be more affected, upper limb. So if there is a wrist, finger, extensor more affected, hand will be like this. You see the position. It is adducted, internally rotated, it is pronated, it is like this, and wrist is flexed. So this posture will adapt in a CST lesion. That means all muscles are not equally involved. This is a particular group of muscle which is more involved. So 3.1, more distal muscle is more involved by CST, corticospinal tract. It is responsible for the voluntary and skilled activity. Number 3, it do not involve a particular muscle. It involve a group of muscle for a particular action. And all group of muscle is not equally involved because the innervation is unequal for the different group of muscles. So next very important question, Dr. Rai can discuss how we can localize the site of the lesion. This is the most common question which is asked in the examination. So lesion can be either cerebral lesion, either cortex, coronary radiata, internal capsule, or it can be brainstem lesion, or it can be high cord lesion. Dr. Rai, can you give some light how the students will?
I can tell. Yes, I think it's a very nice class, but the time is also short. Anyway, I will try to be very brief.
In brief.
Very brief. Already you have written. One important thing is that generally. Am I audible? Am I audible?
Yes,
yes. Pathak sir, mute করে নিন.
Some sound is coming.
Pathak sir একটা মুখ করে নিন.
So if you get a cortical lesion, usually if you want to have a yes, this slide. If you have a cortical lesion, so important feature you must remember, the patient can come with a sudden disorientation. That is very, very important because the stroke, what we are actually vascular territory we are dealing with. So any stroke patient, it is not an subacute or is a chronic process. It is always an acute process. And by definition, stroke is development of a focal or global neurological deficit, which is sudden in onset, the cause of which cannot be explained without a vascular territory. So it is a vascular, it is sudden, and development is very, very, in case some slow process may going on, but within 24 hours, it should last more than 24 hours. 24 hours, you will get the focal neurological or global neurological signs. In cortical lesion, usually patient may be disoriented, may not be disoriented, history of very headache may be there. Then you can come across strategic location can produce seizure, because for the seizure you need to some neuronal activation, excitability, and those neurons which are involved in the stroke, you can produce a seizure. So seizure may be the first manifestation. Then very importantly, you must remember cortex is very important for the language area. We have got two important. I'm not going to language proper. I'm just giving you the brief idea. One is the Broca area. One is which is situated in the frontal lobe and not temporal lobe. You know this very much well. That is the Wernicke's aphasia. What you know is the sensory aphasia or receptive aphasia or expressive aphasia by the Broca. So middle cerebral territory, superior division and inferior division, these two important divisions.
Brief.
Then there is a loss of cortical sensation. We usually test cortical sensation in presence of an intact peripheral sensation. If you have got a peripheral neuropathy, you cannot test the cortical sensation. So patient must not have any peripheral neuropathy. Patient must understand compression must be normal. These are the basic requirements. Otherwise, we will miss out. So what are the cortical sensation? We see about the 1-point localization, 2-point discrimination, graphesthesia, or stereognosis, etc., etc., finger nose agnesia. In case of very classical parietal lobe lesion or Gerstmann syndrome, we get. Then left-right disorientation we can get. Stereognosis we can get. So these are the cortical sensation or perceptual rivalry we can get. In homonymous field defect, this is very important. Homonymous field defect means that one of the particular part of the field is cut off.
Just you mention the points.
That is the
detailing not required. Just mention the points.
Yeah, just mention. And
otherwise we cannot finish.
Capsule, because the fibers are very much compact, they have already taken an 180-degree rotation in the internal capsule. And there are two internal capsule limb, anterior limb, genu and the posterior limb. So if you get a stroke in the internal capsule, there will be a very dense hemiplegia. So in cortical, you do not get a dense hemiplegia. In dense hemiplegia, if you get in a cortical lesion, patient will die because it will be an extensive lesion. Whereas in a case of internal lesion, a small lesion can produce like that. Hemianaesthesia already we have discussed. That is one side of the body which may be due to your thalamic problem, which may be due to the posterior level problem, or which may be due to the internal capsule problem, where the posterior part of the limb is very important. And hemianopia, you all know, the optic radiation and auditory radiations are there in the internal capsule. We can get the hemianopia.
Thank you.
Next slide. So anything else
is
there?
Thank you. So in cortical lesion, we will get the cortical loss of the cortical features, and internal capsule lesion, we will get a more dense hemiplegia, hemianaesthesia. Then is the brainstem lesion. Brainstem lesion basically two important features. One is the cranial nerve involvement. In case of midbrain, we will get third, fourth. In case of pons, we will get 6th, 7th, along with the 5th. And in the medulla, we will get 12th. We can get 12th. We can get 8th. We can get 9th and 10th. We can get the 5th. So these are the cranial nerve involvement. Accordingly, we can get in the brainstem lesion. And very important is the crossed hemiplegia, because nucleus is there. So one-sided hemiplegia, opposite-sided facial palsy. So this type of crossed hemiplegia is another important feature of the brainstem. Another, the ataxia, because cerebral peduncle are attached with the brainstem. So there will be cerebellar feature. And sympathetic trunk that descend from hypothalamus to the upper cervical cord through brainstem. So there may be ipsilateral Horner syndrome. And finally, we are cutting to the cervical cord lesion, particularly the Brown-Séquard cord or the foramen magnum lesion. Here, there will be ipsilateral hemiplegia and, and contralateral hemianaesthesia, because spinothalamic tract crosses before and corticospinal tract crosses at the foramen magnum. And dissociated anesthesia, we can get it here. And ipsilateral loss of vibration and joint position sense, and element lesion at the site of involvement, and EMN lesion below. So one-sided hemiplegia, hemiparesis, opposite side hemianesthesia, and ipsilateral loss of posterior column features. These are the characteristics of the cervical cord lesion that we can get. So there are basically the four areas. One is the cortex, one is the internal capsule, one is the brainstem, one is the cervical cord lesion. Another very important student open up is the postgraduate. What are the features of the foramen magnum lesion? In foramen magnum lesion, very important one is the this is the hemiplegia cruciata, and along with the other features, syringomyelia, pattern of sensory loss, spastic tetraparesis. But this hemiplegia cruciata is very important. I described before that the upper limb fiber crosses rostrally, but lower limb fiber crosses caudally. So if there is lesion, if there is a lesion here, what will happen? What will happen? By that time, upper limb has crossed. So upper limb, suppose lesion here. So upper limb already crossed because it crossed rostrally. So there will be ipsilateral upper limb involvement. But lower limb fiber crosses then caudally. So opposite sided, there will be lower limb involvement. So one-sided upper limb involvement, opposite sided lower limb involvement. Because the difference of crossing of the upper fiber and lower fiber. So this is called the cruciate hemiplegia. This is often found in a foramen magnum lesion. Another important point I forget to take out the peculiarity of CST lesion. When the corticospinal tract get fiber from the primary motor area, premotor area, supplementary motor area, some fiber they receive from sensory cortex also. They descend along the corticospinal tract, but they terminate in the dorsal horn. This corticospinal fiber originating from the sensory cortex is responsible for the sensory motor coordination. Okay, you have given some stimulus, your limb is removed. The sensory motor coordination responsible for this fiber originate from the sensory cortex. Very important finding, if in a patient there is a extensive both sensory and motor involvement, the recovery will be less because this fiber is responsible for the recovery. If there is only motor involvement, recovery will be better. But if there is both motor and sensory involvement of the corticospinal tract, then recovery will be, chance will be poor. So this is the very important of the corticospinal tract, why we do not get the expected result recovery after treatment and giving the physiotherapy. To diagnose the etiology, going into the detail, you have to take whether onset is acute, subacute, or chronic, whether course of illness is monophasic, relapsing, slowly progressive. There is age, sex, fever, headache, weight loss, trauma, and these are the common pathology. It can be either vascular or demyelinating or neoplastic or trauma or different infection. This is the history is required to determine the possible etiology of this presentation. So investigation one done, MRI brain show that small non-hemorrhagic infarct in the left side of the medulla. So this is the CT scan. Any comment from anybody, Dr. Chakraborty, from the CT scan?
My question is that while examining the patient has the deep tendon reflexes in the right side was less. Is what examined in the shock phase or later on?
Okay, when there is a one important feature is to get the exaggerated jerk. Basically, for the few days, jerk may be diminished. Okay, after that, you will get the, usually in the CST lesion, after few days, we get the exaggerated jerk. Okay, same way, we can get the decreased tone. After few days, the tonicity start increasing in the corticospinal tract. That may be the reason why plantar was extension, but jerk was initial days. At the presentation, jerk was depressed. So this is a now Shadavartha. Shadavartha, what is your diagnosis?
What is your diagnosis?
So my diagnosis is a left lateral medullary syndrome with
You stop here. Left lateral medullary syndrome. So what do you mean by that?
So there is a
follow দেখাচ্ছি দেখাও ছবিটা দেখাও না
ছবিটা
ওই তো দেখাচ্ছে শতপথ দেখাচ্ছে তো
এই যে
মেডুলারি সিনড্রোম তো দুরকম মিডিয়াল মেডুলারি এন্ড ল্যাটারাল মেডুলারি তাহলে you tell
sir I think this is a left lateral medullary syndrome because there is involvement of the cranial nerve 5. There is involvement of trigeminal nucleus. The nucleus ambiguous is involved, and along with that I am also suspecting involvement of the vestibular nucleus because of the nystagmus with the
it's okay, but how do you explain the pyramidal fibers?
Sir, maybe because this infarct has extended up in the pons and a bit medial.
We are just discussing. You have got also the hemiparesis.
Yes,
but
sir.
that does classical medullary syndrome
Yes.
involve the pyramidal fibers? It is the
No,
medial.
sir. No, sir. The medial
How can we
medullary syndrome.
explain? How can we explain?
Sorry, I think it can be explained in that way, that it has extended up in the pons, the infarct, and it has involved the pyramidal fibers there.
Yes, it can be have two way. Lateral medullary syndrome, either to involve the corticospinal tract from medulla, the infarction should extend to this area, pyramid, or it should go up to the pons. In the pons, there is a the cortical fibers are dispersed.
We have
They
already
are
got your
dispersed by
MRI.
the pontine nucleus. So, if it extend to this area, there will be more dense hemiparesis or more complete hemiplegia.
You have already got your MRI, which is showing an infarct in the lateral medulla.
Yes.
Is not it? It has not shown any extension to the pons. So how do you explain? The only explanation will be if the pivots, the pyramid, this lesion is extended, the medullary below after the crossing of the pyramidal fibers, if there is any involvement, which sometimes occurs in lateral medullary syndrome, sometimes occurs in lateral medullary syndrome. You can come across very rarely. It is not a very classical, because medullary syndromes are actually medullary syndrome by definition is very classical one you have presented. But Stopford is the one scientist from the German who has shown that the medullary syndromes many 5 varieties. Not only in the only one lateral medullary syndrome, and lot of combinations are there.
Lot of combination is there. I will come to that.
So you should remember this lesion is up to the pontomedullary junction or below that in the cervical level, where the pyramidal fibers have already crossed, as a result of which you are getting the hemiparesis on the same side of the ipsilateral facial numbness.
Basically, lateral medullary syndrome present with more sensory features, medial medullary more with motor features. This is the common dictum. Medial medullary more motor presentation, lateral medullary more sensory presentation. Here only
one last line I like to tell you. We should tell the students, also the patient party, that the swallowing problem will persist, because they can have the feeding through rush tube for a pretty long time. And before you go for the feeding, you should go for a swallow test, and also, if necessary, some of the barium meal.
Yes.
We actually performed, one of the thesis student have done, how long it recovers after lateral medullary syndrome. It may take even 6 months. So don't be very careful about giving food to this patient.
So now very important
My
question.
question to Dr. M.K. Rai, Minalda. So
Yes, sir.
Initially the patient presented with a whole face
একটু জোরে বলো, শোনা যাচ্ছে না।
জোরে বলো, তোমার ইয়েটা
শোনা যাচ্ছে না তোমার কথা।
ভালো করে ইয়ে করে দাও। হ্যাঁ, বলো।
Initially the patient presented with a anesthesia of the whole face, followed by involvement of the half. Why?
That is not very classical of lateral medullary syndrome.
Yes.
The whole face is usually not involved. It is the hemisensory. One part of the face is involved. The whole face is involved.
I am coming to the point. I am coming to the literature. So now question is why whole face is involved. It is not uncommon. So if there is a lateral medullary syndrome, so first opposite sided spinothalamic tract is involved. It is coming like this. So opposite sided hemianaesthesia, that is explained. And same sided, this is the trigeminal nucleus. So same sided face is involved. It is also explained. But why this part of face is involved? Here explanation is, this is the nucleus, there is a descending nucleus. Okay. And this is the trigeminal lemniscus. This crosses, this fiber come from this side, this crosses the midline, go up to the thalamus. So if here it is possible that this side, there is the left-sided trigeminal nucleus involved, along with this trigeminal lemniscus that is from after the crossing, which is going up, both is involved. In that way, both face can be involved. It is not uncommon, because this is the literature, this is not the journal, this is taken from Paul Brugge's Localization of Clinical Neurology. So they have mentioned 51 cases of lateral medullary syndrome about the sensory presentation. Only 13% present with classical sensory loss, 12% bilateral facial sensory loss. Okay, 9% contralateral facial loss of sensation with contralateral hemianaesthesia. 10% only hemianaesthesia. 4% only facial sensory loss, and 2 patients no sensory loss. These are the variant, sensory loss variant that we can get from a patient of lateral medullary syndrome, and I have quoted from the localization of the clinical neurology book. So this is possible.
That I was telling actually in the stop fold is divided into 5 parameters.
Here the trigeminal nucleus and trigeminal lemniscus that is carrying fiber from opposite side and going up to the thalamus, both is involved. In that way, whole face is involved. So finally, we have come to the conclusion. So medial medullary syndrome, to summarize, present with one hypoglossal, medial lemniscus, and corticospinal tract involvement. Lateral medullary syndrome with vestibular, spinothalamic, there is a sympathetic trunk, inferior cerebellar peduncle, and fifth cranial nerve, and spinothalamic tract. These are involved in the classical lateral medullary syndrome. So this is already discussed. So what are the last 2 midbrain syndromes are there? Shatavartha, describe briefly midbrain and Pontine syndrome. So in midbrain, there is one Weber, one Benedict, one Claudy. Shatavartha, what are these? Just tell me what is Weber?
Weber syndrome, the midbrain base is involved, causing the third cranial nerve and cerebral peduncle.
Listen here. Okay. So what will happen?
Sir,
third nerve is coming out. So ipsilateral third nerve, opposite sided hemiparesis.
And
this
in Claude,
Benedict.
Sir, in Benedict there is third cranial nerve, red nucleus, and corticospinal tract involved.
Same thing when lesion extended up to the red nucleus. So there will be opposite sided tremor. And another is the Claudy. What is Claudy?
Claudy, third cranial nerve, red nucleus, and superior cerebellar peduncle is involved, resulting in ataxia.
So here, instead of cerebellar peduncle, the superior cerebellar peduncle will be involved. So red nucleus, third nerve, and superior cerebellar peduncle, not the cerebral peduncle, will be involved. So there will be cerebellar side. So this is the 3 syndrome, common syndrome we see in the midbrain.
I
so
like just I want one thing, Jyotirmoy. I got a case only 2 weeks back. That is your in my chamber. That is a foveal syndrome. In the pons, there is a complete lower motor neuron facial palsy, along with the
yes, I'm coming here. Yes. So pons, what are the syndrome? Dr. Roy or Shatavartha, you can explain. Very common is the Millard-Gubler, Raymond, and Fovili. So Shatavartha, tell what is the Millard-Gubler?
Sir, in Millard-Gubler syndrome, there is involvement of the ipsilateral 6th nerve. There is contralateral hemiparesis and same-sided 7th nerve palsy. And in Raymond syndrome, there is ipsilateral 6th nerve palsy and contralateral hemiparesis only. 7th nerve is not involved. And in Fovil syndrome, there is involvement of the 6th nerve nucleus ipsilaterally and contralateral side hemiparesis and 7th nerve involvement.
Yes. So these are the, so in the medulla, we get basic 2 syndrome, lateral medullary, medial medullary. In the midbrain, we get 3, Weber, Benedict, Claudy. And in the pons, we get basic 3. One is the Fovili, Raymond, and Millard-Gubler. 3 syndrome. So this is the schematic. Last question, just 1 minute, tell me the arterial supply of the brain, and that is the end of the session, then the open discussion.
So there are 2 vertebral arteries which join together to form the basilar artery, and the basilar artery then divides into the posterior cerebral artery, and it is then there is the posterior communicating artery, and there is the anterior cerebral artery which forms the circle of Willis basically.
So basically, medulla, there is a 2 thing. One is the perforator and is the circumferential artery. So midline artery perforator causes the medial medullary syndrome, as circumferential artery causes the lateral medullary syndrome. And lateral medulla lateral part basically supplied by the spinal artery, vertebral artery, and the inferior cerebellar artery. Okay. So pica, posterior inferior cerebellar artery. So that is why in pica lesion we get a lateral medullary syndrome. So this is the end of the discussion. I am thankful to everybody, all panelists, all students who bear 1.5 hour time with us. Now, any comment from the expert?
Jyotirmoy, last slide, 10 second, last slide.
Eta?
Etate ওই এটা একটু তুই কার্সারটা এটা দেখা লাস্ট স্লাইড হ্যাঁ ওই কার্সারটা পোস্টিরিয়র সেরিব্রাল একটা লাইন বলে ছেড়ে দিচ্ছি ওই পোস্টিরিয়র সেরিব্রালে কার্সারটা নিয়ে যা
Posterior inferior এখানে?
না উপরে ওই superior cerebellar artery
ও
পাশে
posterior cerebral এখানটা।
এখানে আছে posterior communicating arteryটা এখানে বের হয়, ঠিক আছে? এইখানে কিন্তু aneurysm হয়. So if the patient has severe headache and ptosis, you should always remember, and along with the pupillary involvement, you should remember
Yes.
that there is some amount of problem in the posterior communicating artery.
Yes. Third nerve come out from the midbrain and passes close to the posterior communicating artery, then enter to the petrous part of the temporal lobe, এরকম ভাবে দিয়ে cavernous sinus এ ঢোকে. So here if there is aneurysm, third nerve will be involved. So third nerve come like this to the petrous part, then to the cavernous sinus, then to the orbit. This is the pathway of the third nerve. So any comment from any others?
Hello.
Dr. Ganguly, please.
Professor Ganguly, welcome.
I am Dr. S.B. Ganguly. This is a very, very good presentation, both for the teachers and also for the student. Now, I want to say one thing. We seldom miss diagnosis at the chamber. Diagnosis is missed in a very near and dear one, whom we see non-professionally. And I think that if a person suffering from vertigo for 2 to 3 days and taking casually Vertin and no result, vertigo with some vomiting, we always think pica.
Yes.
Don't take it casually. So, what the labyrinth and vertigo is the 99% cause of vertigo in elderly, but vertigo not responding to Vertin or Vertigon, along with vomiting, after 2 or 3 days, we must consider pica. Thank you. Otherwise,
yes, this is a very important. I want to give comment on Dr. Ganguly. Very important. Vertigo should not be ignored. And if there is a patient with vertigo, examine the eye. If there is a
For all
nystagma,
vertigo patient, nystagma should be tested.
should be examined.
I fully agree with Shekhar. In last conference in Siliguri, I had a talk on vertigo, and Shekhar has told the right thing. Every patient of vertigo must go for an heat test, head impulse test. If you find that head impulse test is positive, it is peripheral vertigo. If the head impulse test is negative, it is your central vertigo. Vomiting is more common in case of peripheral vertigo than even central. Central vertigo give rise to vomiting only there is rise to intracranial pressure or there is involvement of area postrema.
And posterior cerebral circulation stroke often ignored because does not have much weakness or anesthesia. That is why it is more often considered as a more non-specific symptoms and ignored by the physicians.
Thank you, Dr. Ganguly. Thank you.
Very useful class. Very useful class.
Very useful.
Thank you,
Yes,
everybody.
thank you very much.
Thank you very much,
for this
Professor Pal, and all for wonderful discussion on neurology. Is really is an amazing class.
Firstly, thank you to 2 students, Akash and Shadavat.
Thank you.
They were wonderful. Wonderful.
Thank you. Job.
Any question answer? Any question answer session, or otherwise we will conclude.
Any clarification? এই chat box টা দেখো না।
Chat box এ দেখো।
No chat box, no question.
Chat box, there is no question in the chat box.
Anybody can raise hand.
Now, as chairperson, I have got the one comment before I hand over to Professor Shorkar as a protocol. So I think both the students have done marvelous job under guidance of Professor Jyotirmoy Pal. Jyotirmoy Pal, I have requested him, if possible, he may not be DM, but he can teach the DM people also. So DM neurology, because he is very much, he has a passion for neurology. Always. In master class also, last in my time, I have given him the nystagma, Sekar's pursuit. So it was wonderful. It was wonderful. Anyway, so there is no question. And I think overall the students are benefited. I now hand over to Professor Shorkar for asking for the final comments. And then
Today's master class was really masterpiece, and we learned a lot. Now it's my pleasant duty to ask Professor Pathak, one of our directors, yes, H.S. Pathak, to please give the vote of thanks, and then I will conclude.
Thank you.
So I thank our chairman and secretary, Professor Arvind Sarkar and Professor P.S. Korvakar, to give me this responsibility to take over the final session of the program. In one word, today's master class was an excellent one. Really, it was attended by a record number of attendees, about 100, more than 100, and the presentation discussion by Professor Paul was excellent. I thank Professor M.K. Rai as a chairperson to conduct the session very nicely. The session was excellent. I must congratulate and thank our presenter, Satyabroto, and I thank all those who have, all the faculties, all the program directors who have attended the program, and the interaction was excellent. So with these few words, I thank also the organizer of this micro lab, as well as our office secretary, Mr. Kaushik. So with these few words, I thank everybody for attending today's program and for the success of the program. Thank you.
Thank you.
Thank you all. And now we conclude, and our next class will be in November, maybe on 2nd November, 9th November.
I shall let you let it know to all the attendees in WhatsApp.
Yeah.
Okay.
Okay.
Date is not yet fixed. Thank you. Thank you all.
Thank